Hi, this is Heart Rhythm TV, and I'm Mikhael El-Chami, and it's a pleasure today to host Dr. Julia Indik and Dr. Chris Ellis to discuss the new document, which is a joint venture between Heart Rhythm Society and SCAI, and it's a clinical practice guidelines on the management of patients with left atrial appendage occlusion. Dr. Indik, I'd like to start with you. Can you tell us why this collaboration between Heart Rhythm and SCAI importance, and what's the importance of this document?
Right. So again, thank you for having me. It's really a pleasure to be able to collaborate with SCAI, and I wish we could have more of them here today. What's especially important, and this is obviously a procedure, left atrial appendage occlusion, that is shared by both structuralists and EP physicians. It makes the most sense to create and continue to create documents for patients being treated by obviously both types of cardiologists that merges our best evidence and our best science, and rather than creating chaos by having documents by two separate societies and trying to understand fragmented recommendations. I also just want to give a shout out to SCAI here. They have been a wonderful society to work and partner with, bringing our resources together. They are clearly a society that values and prioritizes the quality of a clinical practice document as HRS does. Our document has really high standards for meeting the National Academy of Medicine, that's Institute of Medicine, requirements for guideline development. It's underpinned by evidence, which is with the technical review panel that I served part of, did the systematic reviews for the evidence. And also I want to really just shout out to the document for being so transparent in how we are constructed, how conflicts of interest are managed, the importance of ensuring that a majority of the document has people without relationships of industry. So anyway, I just want to make sure I get that message loud and clear.
And thank you for this summary. Chris, you were the co-chair of the document. Mm-hmm. Can you tell us, how did you guys come up with the recommendation? And if you want to highlight the 2 or 3 most important points of this document, what would they be?
Sure, that's great. Well, first of all, I definitely shout out to SCAI and Scott Firestone and their group. They really they took the lead on this and brought HRS in, and I think the collaboration is really important because half of these procedures are done by interventional cardiologists. So we would certainly want to be singing the same tune, when it comes to recommendations from a practice guideline. Mm-hmm. I learned a lot about just the process of how to come up with a method that incorporates both the patient in the decision, like what would a patient do in this situation, clinicians, what kind of data would a clinician need to support a recommendation to a patient to do X, Y, or Z, and then also taking into account like a bigger systems picture of the cost effectiveness and availability of the therapy. So that actually, all those factors played into our recommendation for each of the 8 specific questions we wanted to target. We actually started with 12 questions, and we went through this process called a PICO, which apparently is much more, I think in the interventional community, they do that for a lot of their studies. We weren't quite as aware of the process, but we take a population of patients, and we look at an intervention, what's going to be the comparison, and then follow up on what the outcome is, and that guides our guideline. So we took 12 questions, 8 of them got high priority, 4 of them were less prioritized, and so from the top down, the top 3 specific questions that we asked really are about indications. So that is a patient with absolute contraindication to an anticoagulant. Is it better or worse to do appendage closure or do nothing?
Good.
Then patients who have AFib, non-valvular AFib, and a contraindication of some type to a blood thinner, should they be on an anticoagulant or should they get left atrial appendage closure? And you can imagine how the guideline phrases this is going to be super important, right? And that we spent months on. Really, the wording is very carefully chosen. The population that we had no recommendation on when it came to appendage closure is the low-risk patient who's tolerating anticoagulation and has no specific indication for appendage closure. So the committee, we made no recommendation in that because we don't have enough data. We need the data from Catalyst, we need the data from Champion, and combine that with Option. And we should have something, I think, on the next iteration in a few years where we can make a statement.
Okay.
But to me, the biggest takeaway from, like, say, the positive spin about appendage closure would be patients who had non-valvular AFib and some contraindication to anticoagulation. Our highest recommendation in the entire document is that group, and we give it a conditional recommendation with a moderate level of evidence, because we reduce hemorrhagic stroke with appendage closure without significantly increasing ischemic stroke. The procedure has been now seemingly quite safe on the whole when we look at the profile from all the trials and registries, and so it's also cost effective. So we would state it like a patient who has an AFib and a contraindication of some type to anticoagulation would reasonably choose to have their appendage closed over taking anticoagulation. So that took a while to get to that statement, to be able to say, look, that's a population where our recommendation in the committee and guidelines is we would rather close their appendage than recommend taking
and it makes sense. That's where most of the data is.
Correct. And that's and currently that's most of the patients getting treated, right? The high CHA2DS2-VASc, high HAS-BLED score patients. So I think we felt pretty strong. But you can see we had no recommendation of any of those 8 questions that was a strongly recommended treatment. And it's based on the lack of level of certainty. I think some not enough randomized trial data to support saying, like, this is a strong recommendation. So it's still a conditional recommendation.
And part of that conditional recommendation is I also want to emphasize the importance of shared decision making. So many of our patients come to us and they're getting savvier and savvier. They've been doing their reading and their research, and we respect that. They need to be part of this decision, especially when it's conditional, not strong recommendations.
And I did review this document, and 2 things like caught my eye. And one is the lack of recommendation or consensus on how to manage patients with peri-device leak. This is a common issue. And the second one is also what to do long-term with people who have device-related thrombus. Do you put them on lifelong anticoagulation or not? Would one of you comment, or both of you comment?
I would just say, as part of the technical review panel, it was frustrating. The paucity of evidence that is out there. A non-randomized study here, a non-randomized study there, somebody trying to put it together in a meta-analysis, and then us trying to come and put together. And we ended up with point estimates as we, try to come up with this is the effect, with huge, what we call imprecision, a wide range between maybe a little bit harm and maybe a little bit more benefit. And so it was very frustrating. But this, we always want to say we need more data. This is always so true. Some data is going to be easier to come by than not. Thankfully, at least device-related thrombus is a fairly infrequent event, while peri-device leak is more frequent. But a huge question mark is that less than 5 millimeter. And the data we found, the reason why I believe there was no recommendations then made, was because there was no cutting it up by if you gave anticoagulation not based on this size, that size outcome, and they were lumping outcomes together with all of these leaks. So we mostly threw up our hands and said, we can't say.
Any comments?
Yeah, I would say, and specifically the way you ask the question, that's why these PICO questions are like, this is the question, and this is how we're going to try to find the answer. We did not ask, like, does peri-device leak cause stroke? That's not the question. The question is, do you have to anticoagulate everybody with a peri-device leak? And the answer is no recommendation. We got nothing there. Then the next one is DRT. The question is, all patients who have a DRT should get no therapy or should go on lifelong anticoagulation. So again, not able to make a recommendation. It's a tough...
and we don't even know when to re-image. There's a lot of those. And how long, or should it be in?
Sure. It basically highlight the lack of evidence in this field, in some aspect of this field.
And that also layered into the imaging questions, about pre-procedure imaging or ICE versus TEE. One thing I found interesting in all the analysis was this trend towards increased mortality, per se, with ICE-guided appendage closure versus TE. Now, I felt like looking at that, I'm like, yeah, it was 5 additional deaths per 1,000 patients treated. But there's, previous, I think, standards that when an event like that exceeds 10 events in 1,000 treated patients, it would have changed how we phrased the
right. And what we did and what was asked of us in our technical review is say, well, what do you feel would be a clinically relevant number? And so we felt with 10. But I would also speak to the ICE and the mortality. Again, these are not randomized trials. Yeah. These are different. Why did they get ICE? Maybe because they had esophageal varices. Maybe that's what predisposed them to higher mortality. So we really don't know.
Well, I'd like to thank you both for summarizing this document. We're all looking forward to seeing it in print tomorrow. Thank you again for discussing this with us today. Thank you.
Thank you for having us.